Again, it's the 1960s, and we're talking about the reactions of various people within the hospital, within the medical care system, within the hospital system, to Elisabeth Kubler-Ross. She's a very young consultant, and she decided to work on an area that nobody wants to care about. She wanted to figure out what's happening psychosocially, psycho-emotionally to the terminally ill. The doctors, the people in the hospital, cannot do anything for you anymore to cure your disease, and your disease is going to kill you. Of course, it doesn't really mean terminal. It only means you're terminal as far as the medical cure is concerned, but it's the 1960s. The medical view has taken hold over the idea of well-being, health, and death and dying. The only way for you to get cured is through the medical profession, is through the medical practitioners, through the hospital. There's no such thing as cure from any other causes. There's no such thing as cure from faith or belief, or a belief system that believes that whatever the doctor does, or whatever the hospital system comes up with, ultimately the healing will come from someplace else. That's 70 to 80 years ago. Now, 70 to 80 years later, well, you see the result. There's no such thing anymore. God, if you have the Christian or Catholic or Judeo-Christian belief, God cannot heal you directly. He heals you through the doctors and the hospitals. And unfortunately, he heals you through the doctors, through medical science, which doesn't believe in God. The medical care system, who looks at patients, that objectivizes patients, and has been trying its best for the past 60 or so years to remove the idea of God, faith, spirituality, spiritual healing, and things like that out of the system. God works through the atheist, or God works through the agnostic, or God works through the devil in disguise, if you want to. If you think that way. I mean, if you consider a situation where the system is trying to remove God, what else would you call it, right? So that's the ultimate goal of the anti-God, right? But anyway, that's not the topic. So she's there, she's walking around, and people thought she's crazy, or she probably has some other agenda in mind. Maybe she thinks she can earn something out of this thing, or maybe she thinks she'll get famous. But obviously, she's not thinking that, because it's terribly hard. How hard is it? It's so hard that she wanted to give up most of the time. It's so hard that she wanted to give up most of the time. During the first 12 months, she describes it as extremely, very difficult. I almost wanted to give up. And the only thing that kept her going is the few nurses who thought it was very important, usually the younger ones, and the few doctors who think it was important, usually the very old ones or the very young ones, but the great majority, those along the middle ground, think it's such a useless, worthless undertaking. And they think she's wasting her time, her effort, and she's wasting their time, their effort. Actually, not just wasting, she's a terrible irritation. So she would walk around. This is a big hospital. I mean, this is like in the middle of a big metropolitan area, Chicago. And it's a teaching hospital. It's a training hospital. So you can imagine the big, modern, during that time, 1960s, training, 1960s, 1970s, training hospital. Then what you will see is a lot of people moving about. So there's a whole bunch of patients, because it's a very big institution. She had wards. They had wards during those times. And there's trainees, there's older nurses teaching younger nurses, there's older doctors training younger doctors, the surgeons, the medical people, the clinicians, and all sorts of things. And then there's people lined up in the ward. And like we talked about in the previous session, the terminally ill are placed in a separate place. Why? Because it's just more efficient. They're the kind of people who don't need to be cared for too much because, they're dying anyway. There's nothing for us to do. We can't care for them because we cannot cure them. So there's this, you can only cure by curing attitude. And of course, it's 1960s. When I say 1960s, you think about just a few decades ago, they had this atom bomb, nuclear power, and then we had the moon landing program, the Apollo programs, very optimistic ideas about what science will do. Most people think that, given a few decades, it will cure everything, which is pretty crazy. I mean, looking at their situation from our perspective, they're so optimistic, and they show off their machines, and then you look at their machines. What the heck is that? I mean, your cell phone is more complicated than that, and we have fancy cell phones and things like that compared to their super computers and super machines. And even with our little cell phones, we cannot cure most of the diseases that's been killing people 70 to 80 years later. So it's just a crazy idea. Actually, we still think that way. We just don't see it. It's harder to see when it's happening. It's easier to see decades later in hindsight, right? So consider the pandemic, how we reacted to it, using whatever we learned or whatever we've been doing as far as medical science is concerned. And sometimes you think, where did the common sense go to? It's a crisis and science is very slow, and what are these idiots doing? But anyway, that's not the topic. This almost religion-like attitude towards medical science, that's the only way to go. And the people who died, just because we haven't solved it yet, we just have to sacrifice that. They're part of the victims along the way. This is the only way to go. Of course, in hindsight, if we look at what they can do, how little they can do, of course they thought they can do a lot. We will be thinking, that's not the only way to go. You should have been doing this while you were doing that. And I'm pretty sure several decades from now, we'll probably be saying, that's not the way to go. You should be doing a lot of this while you're doing that. If it's just a simple matter of trying to prevent people from dying because of the pandemic. Of course, we know there are other factors involved, and a lot of them have nothing to do about saving people, right? Anyway, so she's walking around the ward, and she almost wanted to give up. So, but one day, she was feeling so exhausted, frustrated, and, begging for more help. I mean, she'd had some help from the very few nurses who think she's onto something. There's still very, very few young trainee doctors, and very few aging doctors who are still working in the hospital. Those are the people who sense that there's something to it. And we've talked about that in the previous sessions. And other than that, she wasn't getting a lot of help. It's just this Kubler-Ross doctor from psychiatry doing something nobody else is doing, and something very strange, and such a waste of walking up and down the ward. And she actually said she had to walk miles and miles of corridors, going back and forth, trying to figure out who will be open to her idea, which doctors would go along with it, the doctors she needs to stay away from, and the few doctors are willing to help her. Then, looking for patients to interview, dying patients to interview, and getting people to, at least attend some of her seminars. She actually said, as far as attendees are concerned, what she's getting is a lot of nurses, very few doctors compared to nurses, and surprisingly, a lot of pastoral care providers, theology students, spiritual care providers, which brings us to the topic right now. So while she was walking down this corridor, she met an equally exhausted, equally frustrated, and equally troubled, filled with patient-related problems related to terminal diagnosis, related to emotional crisis, related to dying. And who is that person? The hospital chaplain, the pastoral care provider, the priest, the pastor, the hospital chaplain. And this is a small group. It's probably just one Same situation as now, just one person, or maybe 2 or 3 taking turns. You won't last if you're the only one there. But I'm pretty sure in some hospitals, there's just one. And why is he exhausted, frustrated? Probably also wanting to quit. Of course, you can't quit. If you're a chaplain, quitting is like, doing a Jonah. You know what happens to people who quit when God tells them to do something. You don't want to do that, right? Yeah, Jonah the whale, and you don't want to do that. So it's very tired. And guess what the reaction is? In so many words, it sounded like the hospital chaplain said, well, thank God, chaplain, you're here. Now I have someone to help me out. A doctor, and not a very influential one, and not a very popular one, but at least a doctor who thinks that this area of care is very, very important, who's interested in actually talking to the patients referred to me. So they referred to me. Why? Because during that time, chaplains played the role of the clinical psychologist, the counselor, the hospice counselor, the psychosocial support person, the family support person, the therapist, and everyone else. So death, dying, terminal illness, just got told, emotional crisis, patient, family, having hard time, everything gets referred to the hospital chaplain, to the group of the priests, the nuns, the pastors, and the ministers. Of course, the first question is, why do they do that? Obviously, this poor chaplain is very exhausted. Why are they making him do all those things? Well, for one thing, he's not a medical person. He doesn't know, or he doesn't understand all the medical stuff that has happened for the past few days or the past weeks that's causing or that triggered all this crisis. So the only way he can approach this is, you're dying as far as your doctors are concerned, and let's talk about your death, or let's talk about dying, or let's talk about suffering or your fears. And the only thing he can offer is, like verses or scriptures to make the patient or the dying person feel better as far as death and dying is concerned, or as far as suffering is concerned. And of course, there are several scriptures to that effect. But the problem is, most of these emotional crisis and even a spiritual crisis is being triggered by the medical context, the hospital environment, the people inside the hospital, the doctors, the way they explain things, the way they present the disease, the way they present the progression of the disease, the hyper focus on how the disease is not getting stopped and how the patient's not going to be saved, and poor patient and poor you. We want to talk to the priest because we certainly don't know what to tell you. That's the trigger, right? And so what actually happens during that time, and it still happens now because I meet a lot of chaplains, pastors, ministers, and nuns walking around hospitals, in several hospitals. I won't name which ones. And I ask them how things are doing. And usually the thing they tell me is the same idea. They're exhausted, they're frustrated, they have a lot of problems. And you know why? Because a lot of those problems are problems they can solve. When they talk to the patient, 80 to 90% of the time, the problem has nothing to do with, cannot be solved purely by prayer and things like that. The patient says, we're confused, we don't know what's happening. The doctor says this, but that's all he tells us. We don't know if it's our right to tell the doctor to tell us more. And even if he tells us the diagnosis, we can't understand half of what they're saying. It's so technical. Even during the time when they gathered around trying to be nice and did their interdisciplinary meeting with us, we can barely understand it. And it has nothing to do with how we feel about it. They try their best to be nice. They smile, they patronize us sometimes. And I think that's as far as they can go in terms of acting like human beings or trying to be personal, but it's deeply personal and it's not helping. It's like listening to a lecture about our family members about to die. We almost wanted to tell them to just, go outside and talk about it and just, go back to us and talk to us like normal human beings. It's still happening right now. You can imagine, as early as the 1960s, training institutions are so proud of what they're doing. It's like we use first names and we're polite, and of course, looking at it from another perspective, well, if you're a human being, you ought to be doing that. What's so spectacular about that? The only thing that would make that spectacular is for some reason you became less human and now you're becoming more human. Maybe your training turned you into something less human, right? Anyway, that's not the topic. So the chaplain was having problems, and he was very thankful. He gets scolded for all sorts of things. He says he gets scolded for disclosure. The doctor comes in and it's all we can do, and tries to nod, tries to almost like pity. Obviously, the patient and family member are in an emotional crisis, and then they say, we'll get the chaplain in, we'll call sister so-and-so, or we'll call pastor or father so-and-so, and then they get out of the room, and that's pretty much it. So they deal with emotional crisis, family difficulties. They play the mediator. They are asked to mediate between family members and between the family and the doctor and things like that. If you're in hospice, you know how it feels like, because it's still being done. Right? They don't call the chaplain anymore, or most of the time they call the hospice and or palliative care practitioner, right? But it's the same situation. You get called in, you have absolutely no idea what happened days before, weeks before, and they're very emotional, they're very confused, and they're about to die in the next, 1 to 2 weeks, or they're about to go home in the next few days. Go do your stuff. And of course, whatever that stuff is, and it's probably much, much less than what the patient really needs, or what can you do? Even if you have like a gazillion degrees attached to your name, you have a few days or a few weeks. This is a huge problem. Even the best counselors or therapists cannot solve this kind of situation in 5 days. They would need about several weeks or several months of therapy, and obviously there's no such thing. So what can you do? So the hospital chaplain became the scapegoat of the system during that time. In the same manner that the hospice care people are the ones, the black box scapegoat. Like, what happened to Mr. So-and-so, the super specialist, famous consultant from another field will say. And then the trainee will say, she's dying and she's very sad and she's in shock, but we already referred them to hospice. And then the consultant obviously doesn't know about death and dying. We just say, very good, and let's go on and discuss the next patient, because that's obviously not interesting anymore. Same idea. So the chaplain gets given a whole slew of names. This is like a tertiary referral center in Chicago, and he has to try to address all the problems and the emotional crisis of each one of them, especially those dealing with death and dying. Right? And I'm guessing that's not his only duty. Like right now, that's not the only thing they are supposed to do. They are supposed to hold masses and supposed to visit some houses, and they have other things to do other than go room to room. In some well-resourced places or well-resourced hospital or medical care institutions, they're in-house. The only thing they need to do are the stuff that needs to be done inside the care system, maybe a conference inside the academic medical center, or some mass or patient visits, but at least it's not as bad as doing everything inside and outside the hospital. But you can imagine how difficult it is. So he was so happy when he saw Kubler-Ross. And so that's 1 year of desperation and difficulty. Suddenly it seems like they found each other. Things became easy. Right? The consultants already referred to the chaplain. They don't like Kubler-Ross. She's a doctor. She's a psychiatrist. What would she do? We don't want something like that. We want someone who has no idea about the medical and the clinical stuff that happened, who wouldn't think that we failed, or who wouldn't notice that we didn't do such a good job medically. What would a chaplain? We want that. So they referred all the cases to the chaplain, and the chaplain has all this list, and she approached patients with him. So they're working with each other. So she had an easier time. Actually, what she said was, Now it's just a matter of picking the ones who need it the most. That would make sense. But, if you ask why, well, probably there's too many, right? And again, this is a tertiary hospital, huge tertiary hospital. People go in there because they're very sick. A lot of them will die. And if you see this hospital chaplain and this consultant doing something strange, interviewing people, and that against dozens or maybe even hundreds of people referred to them for all sorts of huge crises that you cannot solve with just one visit, they still have their work cut out for them. And so they had to choose which ones to help and which ones they cannot, right? So what does that tell you? Even as early as the 1960s, 1970s, nobody cares about the psycho-emotional and psychosocial aspect of caring. It's all medical. The only psycho-emotional, personal, compassion thing that's going on is probably, I sat down, I felt sad when I talked to the patient. Oh, you're so good. Things like that. Or I used the first name. Right now, I even heard someone say, you should be nice to the patient. I teach my students to write generic, and then all the other consultants will nod and, oh, that's very charitable. Is that the only thing you did? Yes. Of course, they didn't say that. That's as bad as it gets, right? It's already bad before, and, instead of improving, it got worse. Even with the establishment of hospice and palliative care. We just created another hospital chaplain, and we actually created something better than a hospital chaplain. We created a hospital chaplain plus a way to get patients out of the hospital and out of our sites, right? Hospice home care. Of course, you don't give them resources, so whatever problem happens, it doesn't happen in front of our eyes. Especially now, a lot of hospices in developed, there are multiple healthcare, medical care crises during the past decade. A lot of hospices went into financial trouble. Why? Because, what's the first thing you'll sacrifice? Dying people, right? It's not a great model. You don't create a separate band-aid system to take care of what everyone else ought to be doing. You create that system to help them out, not to take care of the stuff they'd rather not do. It's not going to work. And especially if you're not going to pour in enough resources for that kind of an idea to work. And who would, right? You don't earn money from them. You feel bad when you see them. And you can't do anything for them as far as these medical care professionals are concerned. So anyway, it's still work in progress. I have some ideas on how things will pan out, but of course this pandemic introduced another major element. You're looking at the situation where there's not a lot of resources in several countries to take care of everything. Food, healthcare. Yeah. So anyway, that's not the topic right now. So what did she find out? Well, let me tell you, just because they're pastors, ministers, priests, nuns, it doesn't mean they're not human. So the problems of the nurses and the doctors are the same problems of the hospital chaplain and the spiritual care providers. So what's the initial reaction? The initial reaction is lesser in number, not the great majority like the doctors, but a good number would be hostility, avoidance, and sometimes even anger or irritation. Hostility, avoidance, anger, and irritation, and for the same reasons. Like in the previous sessions when we talked about doctors and nurses. Why would you feel that? Because a dying person tells you or shows you what can happen to you. That's one. There are lots of reasons, but I'll point out one or two. The other reason is, especially for the care providers, you have to do something, but you don't know what to do. And the third one would be, which only applies probably to the doctors, is it's a reminder that whatever you tried to do didn't work. You failed. And failure makes you feel worse. Doesn't make you feel better. Maybe during your training, you were told that failure is not an option. Of course, that's not true. You're not God, right? People will die. Even you will die. What do you have? It's constant state of denial of reality. You can't keep anyone alive forever. And no matter how smart you are, your patients or some of your patients will die sooner than you would want them to die, right? So same with spiritual care providers and the chaplain. How is that? Because the training is also difficult. I mean, it's happening right now. It's worse right now, but it's already happening during that time. Exposure to actual death, dying issues, emotional issues, issues of the patient family related to this, suffering, severe illness. You don't get to see a lot of things like that during training. When you enter the seminary, you don't see a lot of that. You talk about it. You know, just like med school, you talk about it in a very cerebral manner. Of course, med school, you talk about, like, you enumerate the signs of death, how to pronounce somebody who's dead, and you talk about the heart and the brain and the kidney and things like that. Of course, you're not really talking about people. You're talking about an objectified person who's dying. Of course, that's not, when you approach a bed, that's an actual person just like you who's dying, and then suddenly you're stopped. You realize there's more to it than that, right? In seminaries, that's the same thing. You talk about the different scriptures or verses or doctrines about death and dying, and memorize them, and pray about it, but you haven't really seen a lot of people reacting very subjectively in a variety of ways, very personally, to the fact that they're about to die. You haven't seen a wife who's so miserable because her husband is about to die, or a mom who's about to lose a kid, and suddenly you realize you're reacting to it just like any other normal human being would. So it's not a lecture anymore. It's not an exam anymore. It's the actual person in front of you. So how do you react to something like that? You try to avoid it. You feel angry if you cannot avoid it. You feel angry if there's someone who keeps on bugging you about it. And that's what, Kubler-Ross represents. But anyway, that's the initial impact, just like the nurses. That's the initial impact. But a good number also realized how important it is, especially if you're a chaplain. That's part of the value system. In the United States, that would be Christian, Protestant, Catholic kind of value system. You cannot not try to show caring and compassion, right? And so what happens? What else did she discover? Well, priests do the same thing, or something similar to what doctors do. What do doctors do? Like what we discussed in previous sessions. They sit down, they get the chart, they look at the chart, they show them the results of the x-rays or whatever gadgets they have during that time, or the blood test. They explain it completely. And then, of course, the patient and family, none of them went to nursing school, medical school. Right? Just listening to them. You're just waiting for the punchline. And the punchline is you're getting worse and you might die. Or you're certainly going to die as far as I'm concerned. Of course, you won't hear as far as I'm concerned, but, as far as God is concerned and as far as spiritual healing is concerned, we don't know. We don't hear that anymore. That's like a century before her time, which is something to really think about. By 1960s, they've successfully taken God out of the healing profession or the healing business. Right? Or God works through us. But, it's an ungodly system and ungodly environment filled with atheists and agnostics. So God works through the non-godly, which is really strange. I don't think scriptures say that, but anyway, that's not the topic. So what do? The spiritual care providers do the same thing. They take out the scripture and they read a couple of verses and do the prayer thing, but they don't really try to sit down and ask them how they're feeling and about their spiritual issues, whether they're angry with God, and well, they can do that, but they don't go beyond that, like their relations with the daughter or the husband. It's like a huge mess sometimes. The mom feeling bad because her young kid will be left without a mom, and especially the topic about fearing death and dying and all the suffering. Of course, you have answers for that. I mean, if you're the chaplain or the priest or minister, you have the scriptural answers for that. But before you say that, the first order of business is to sit down and try to listen to the person, tell her story, and tell you exactly what her problem is. Not just put them in one box and then recite the 6 scriptures that you think is applicable and then call it a day. You don't do that. But it's so difficult even for chaplains, nuns, and priests, and ministers, and pastors. So that's one way they avoid the situation. The other way is just to do whatever sacrament they need to do, the blessing, and then get out of the room. And it happens even now. Even when I ask them point blank, they tell me many of them are guilty with that because it's also difficult for them. Becoming a chaplain or a priest or a minister or a nun doesn't turn you into something that's not human. They're still human beings reacting to death and dying. So it's difficult for them. And there's not a lot of things during their training that would help them out. Actually, the trainees, the spiritual care trainees, later on sought Kubler-Ross. So the people who actually sought Kubler-Ross, yeah, there are some doctors, but a majority would be the nurses. Why? Because they think, that's their job. They see the patient every day. They're supposed to be caring for them and talking to them. And they see there's one huge mess as far as the terminally ill is concerned. And, they see the science and they're happy with it. But during that time, but right now, we're heading in the wrong direction for the past 70 to 80 years and nobody even cares about that. And it's back to referring to the priest or hospice. That's what we're doing right now in many places. I won't specify which ones. And she had theology students and nuns and priests and pastors in training. Why? Because they want to experience the real thing before they actually become a spiritual provider for the sick and the dying and the terminally ill. It's one thing to talk scriptures and theory and theology. It's another to experience sitting down and trying to understand and trying to empathize and trying to discover whether you still have some compassion left in you or not. Even for doctors, probably it's a good idea to, before you graduate or while you're practicing, while you're a consultant, to sit down, try to understand, try to empathize, and try to figure out if there's any compassion left in you or not. What that compassion would make you do, or whether it will actually make you do something. So that would be interesting. I don't know what you'll find, but anyway. So they found each other and they helped each other out. And let's end with, this is one of her favorite stories. She talks about a theology student, very interested, very active, really trying to help her out. They're very interested in helping out the terminally ill, the sick and the dying. It's always there. Even helps out with her seminars. And what she said was, it wasn't her or whatever they're doing now, that changed this person's values or that created this person's values, that gave this person compassion. You compare this theology student with the rest of them, he's definitely different. And then she says, the thing that's different about him is, for a while he has been struggling with this idea that he might have a disease or that he has a disease that will kill him. Of course, he got better, but experiencing the disease and all the emotions that go along with it, the shock, the denial, the anxiety, the fear, and going through the stages of Kubler-Ross, is probably one of the most important sources of her future ideas about the stages of grief. He went through all the stages and back and forth, and makes him appreciate more the struggle and the difficulties, or the very personal, the very human reactions for all these patients in that situation, because somehow he had a taste of it, right? And then he also experienced the support of his wife, his kids, and he knew that it was very helpful having someone sitting down trying to understand you, having someone in front of you talking to you, caring about how you feel, trying to understand you, trying to help you in whatever way they can. That makes you feel better. It's very important. And then, of course, he looks at these patients placed in these areas of the hospital, barely getting a lot of visits from the doctors anymore, and the nurses doing some talking, but they're very busy, and some of them don't really like the idea of being too personal. He sees there's something wrong with that because he has experienced it. So it's really difficult to change attitudes and values. I mean, it doesn't mean it's an excuse, right? Maybe there's a reason to worry where they were heading, 1960s. Of course, we can tell them right now, your fears are justified. I mean, whatever you worried about, it's happening, and it actually happened. But there you go. It's important. It's the human thing to do. If you hold the values of any of the major religions in the world, especially the Judeo-Christian or the Christian or the Catholic belief systems, you have to be doing it, right? You cannot fracture your being into separate parts. The part that goes to church and then sings praises and says they believe and they will follow, and then the one who goes to the hospital and does something different, and then the one who goes out and does charity mission work to sort of apologize for the behavior when they deal with patients. It doesn't work. So that's the hospital chaplain. There's actually one more, the students. We'll try to discuss that one of these days.